Thank you all for joining us today for another episode of our podcast, Moving to Value Unscripted. My name is Dr. John Rodas, and I'm a recovering ex-hospital president and am proud to be the president of the Moving to Value Alliance. The Moving to Value Alliance, MTVA, a 501c3 nonprofit, is a multi-stakeholder grassroots organization whose purpose, put simply, is to foster a community that aims to create a value-based healthcare ecosystem with high-quality outcomes at a reasonable cost for plan sponsors and their members, beneficiaries, or employees. I want to thank our members who make this presentation possible. We'd like to give special recognition today to our trade member, Hartford Healthcare. I'm joined today by my fellow board members, Lisa Trumbull and Dr. Steve Schutzer. Lisa Trumbull is the CEO of Sohn Health, Southern New England Healthcare Organization, a physician-led, clinically integrated delivery system in Connecticut and Massachusetts. Dr. Steve Schutzer, a nationally renowned arthroplasty surgeon, is one of the founders of MTVA and is the co-founder and president of Upswing Health. Our special guest today is Mary Tracy Mock. Mary is an experienced healthcare executive with over 35 years of experience in payer-provider contracting. Mary has a deep understanding of healthcare delivery systems and knows the ins and outs of contracting arrangements. She is the CEO and founder of MTM Value-Based Care Strategies and Solutions, where she advises clients ranging from health plans and direct primary care enterprises to EHR platforms on implementing innovative strategies and care models. Mary has led value-based care arrangements and provider network development for a variety of organizations, and she's passionate about advancing solutions that support accountability and better health outcomes. We're so excited to have Mary here with us today to talk about how to improve primary care payment models. Welcome to Moving to Value Unscripted, Mary.
Thank you so much, John, and pleased to share my thoughts. I don't know that they'll be consistent with everybody else's thoughts on the value-based care proposition. And again, as John mentioned, I'm passionate about mainly primary care and how to support our front line, particularly as we are seeing more and more written about losing and having a primary care crisis. I think the last one I saw, Lisa, was in Massachusetts, kind of sending out a cry for help. And how do we advance and make attractive the practice of primary care? So that's where I am spending most of my time right now. And I will say it's the good, the bad, and the ugly out there.
I think what you're referencing, Mary, is the Health Policy Commission report that there's a dearth of primary care assets in the state of Massachusetts, which is true nationally. So it should be an interesting conversation.
Yeah, and you've seen a lot of change, obviously, over 35 years. You really have the long-term view of the good times, the bad times, the good times, the bad times. It's these pendulums have swung back and forth. So, Mary, before we kick into the meat, it's part of our tradition here to ask our guests kind of their journey, how they got here. If you could kind of think back to how the heck did I ever get started in this kind of world of value-based care, I think our listeners would appreciate it.
Probably looking back, how I got into healthcare in the first place was through the clinical side. And it really came down to this. I was a graduate from the University of Colorado. I had nothing planned for the rest of my life when I finally got my degree. And I decided I either wanted to be a flight attendant for United Airlines or I'd apply to medical technology school, because back then CU had a med tech program. And guess which one I did? I did the medical technology. And then I got accepted to United afterwards. So I, boldly walked forth into being what's now called a laboratory scientist. And it was interesting. It was stimulating to a certain degree, but it was only going to take me so far. So ended up going back and getting a master's in health administration. And my first big opportunity was with a consulting company. And also they were healthcare architects. And then they had a consulting division as well, who did a lot of the income distributions for the major multi-specialty group practices around the country, like Carl and Ochsner in Louisiana. This was a long time ago. And he would put their income distribution programs together and had this little tap on the shoulder from Blue Cross Blue Shield of Colorado and one of the big multi-specialty group practices who wanted to go into an integrated plan. Now, mind you, this is in the 80s, and I'm talking 1980.
Great.
So started to cut my teeth on that, dealing with St. Joseph's Hospital, which was a Catholic faith-based hospital run by some very, very gutsy nuns at that point, was just an eye-opening experience. So when what is now HCA, then was AMI, tapped me on the shoulder and said, "Hey, do you want to come over and help the CFO figure out these payer contracts?" And I thought, okay, why wouldn't I? So jumped over there and spent a good amount of time with the hospital systems. And then they got this wild idea of like, well, we've got three big hospitals in Metro Denver. Why don't we just buy a health plan? That way we have beds to put everybody in. We have beds that can get filled by this
Right.
health plan. So
Right.
I jumped over to the health plan, and that's where the fun began because
That's
it was a
right.
very innovative group of individuals and was not shy about alternative payment models. So we were doing alternative payment models in the late 80s, early 90s. And in fact, pretty much in step with what Monarch was doing out in Orange County and putting a primary care capitation program together. So I had the pleasure and the honor of helping craft that program for Metro Denver for a health plan, which was then called CompraCare. It eventually evolved into Secure Horizons, which is a United asset. And we pulled together, a primary care capitation program. And it was not easy, but it was fascinating. And was it perfect? Absolutely not. And we just kept at it and improving it. And then I'd say we probably got a little bit over our ski tips in regards to capitating everything. Like Orphan said,
Specialist and primary care.
yeah, let's get cardiologists capitated.
Right.
Let's get radiologists capitated. Let's do this. And so I think I made you guys laugh when we talked about this the first time. Not only did I get to put these capitation programs together, I got to decapitate them. They weren't working. And,
I bet.
Yeah.
and that is a scary word. And that is a
Yeah.
very scary
Yeah.
word because
Crazy.
not everybody was as gifted and as wise about the reserves that were necessary
Right.
to this, but we did have good success stories, really good success stories back then. And then, of
Amazing.
course, too much risk was transferred without appropriate stopgap, without appropriate measures. And the Division of Insurances, not just in Colorado, but all around the country, were starting to wind it back. Like, oh, wait a minute, no. So we went through that piece, that moment in the early through the 90s of just not doing anything innovative with alternative payment models. And then everything started to kind of creep out once we got into the 21st century to see, okay, what are we doing next? And now here we are.
It's amazing how long ago this stuff was going on. And,
It
and,
is.
you were making me think about the era we're talking about. I was in residency in New Jersey, and DRGs were just about to happen. And they
Yeah.
actually started in Jersey as a test year. And I remember and I also trained at Catholic Hospital. And I remember the nun who ran the place, Sister Jane, we were all like, what does this mean? What does diagnosis related grouping mean? So we're going to pay a fixed amount for the diagnosis, no matter how much we did to a patient. And honestly, I don't think most providers on the hospital side figured out even what that meant for 20 years. They kept saying, oh, I ordered another MRI because it's good for the hospital. You make more money. I said, no, 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 we don't get paid that way.
Yeah.
Wow. Steve?
No, just Mary, that's a great insight you just gave. Because, capitation is coming back, and how broad it will be today may be different than 30 some years ago. But I always wonder why it didn't work. And you just gave a great insight. So you just got a little too far, right? A little too maybe beyond the original mission. I think that's an interesting point.
Thank you, Steve. We did get over our ski tips, as I like to say. I mean, talking about cardiology and radiology and all of the developments that were starting to happen then that made them kind of intersect. And the turf wars were absolutely astounding. And you could get yourself in the middle of all of that. And just having that kind of knowledge led me to make some pretty bold recommendations and statements around an organization that I worked for, probably 10 plus years ago, who really fancied themselves as being able to acquire and manage a capitated cardiology group in Southern California when they had no business managing a capitated cardiology group. Plus, the cardiology group, while they said they were capitated by the MSO that worked with them, it was a capitation light model. So I think everybody just sort of took this new direction, like from 2013, 14, 15, and just ran with it and pretended. I mean, they thought they knew what capitation was, but they really didn't. And there's episodic prepayment. And then there's what I would call the primary care capitation model, or the DPC model, which is the one I'm really leaning into at this point, is somewhere between those two models. Lisa, you look like you want to say something.
No, I was having a flashback as you were talking, because I was on the other end of that spear, running a large, medical group that was pursuing capitation, because it was big, back in the days. And I look at where we were then and where we are now, and nobody was prepared for capitation. It was a play that was being made by the commercial carriers for the most part, right? To cut costs and manage margin and eke some more profit out. And as a result, it did end up working in the long run. But, on the other side, on the provider side, there wasn't any understanding of the time, resources, and tools needed to be able to manage capitation and all the complexities that you just explained. And I look at where we are now, and I think that there's so much more sophistication to be able to move in that direction. And I'm curious to see if you have that same perspective of the pluses and minuses of capitation and the kind of general understanding and capabilities of the industry right now.
Well, I could give you that perspective, but when you look at specialty care, that's a whole different setup around what we call value-based care. And I do have to say, this is a pretty funny story. I was coming back from California, moving back into the Colorado market, and I kind of checked out of healthcare for a while. And I didn't really embrace the value-based care thing. So I applied for a CIN, clinically integrated network that was coming up, and applied using all the old language, and they refused me and said I wasn't qualified for the job. Which I was like, what?
Yeah.
That's funny.
What? At least now we have AI that can help change some of that and get you straightened away. But I definitely needed AI back then. But you know what? I think the challenges are still there. And what I have really enjoyed watching in the direct primary care space is that they're taking away, they don't participate in the classical DPC, meaning direct between the primary care physician and the consumer, and they're doing somewhat of the same into the employer as well, is that they're just walking away from some of the basics. Like, they don't credential, they don't report, so they don't have these massive reporting systems. Now, for the consumer, that's, buyer beware, have your eyes open. And on the record, I have had a direct primary care relationship with Dr. Bree Seefelt for going on 7 years. And it's wonderful. It's unencumbered. They show up to work enthusiastic. They're available. I've been able to asynchronously text. I've been able to get what I need done. And she takes care of very complex cases. She's also an osteopathic physician, so does all of the osteopathic manipulations. And it's very clear what is included in my membership versus what I'm going to pay extra for. And I personally think that is not a bad thing to offer to the consumer, because it gets the consumers engaged, or the patients, I should say, engaged, and makes them a partner in making some of these healthcare decisions, instead of just going to a doctor and being told and then coming back. And a lot of my friends just call me and said, well, what does this mean? And I'm like, well, why are you asking me? You should be talking to the doctor. Well, they only have 15 minutes. They want to bill for phone calls. They want to insulate themselves because they're overloaded.
It's almost like a concierge. It becomes a semi-concierge practice. But let me pick up on this, Mary. Let me ask you, from the employee's perspective, the employer. Here in Connecticut, we have a lot of small manufacturing companies that have, 100 employees, and it doesn't have to be on the factory site, but in our community, we've partnered with Dr. Jones's group, and they're going to take care of all your primary care needs. They're going to be the ones, and this is how you get in touch with them, and here's their office, blah, blah, blah. But, we have a gig economy. We have people working remotely. We have people working all over the country, all over the world. How does that work? How does DPC work in that model? And then and just to segue to that, where does virtual care and telehealth fill that void? And not to mention, by the way, the timeline. My kids, who are not kids anymore, they're adults, were never going to pick up a phone, dial an office, be on hold, make an appointment 4 months from now, and then go sit in a waiting room somewhere. They look at me like it's crazy. So why do you guys do that? So if you could what's the future kind of world of a DPC look like?
You know what? That is a really good question. And I wish I had the looking glass to tell you. I do know that it is growing one doctor at a time that have aggregated into businesses. If you look at like Nextera Health or Frontier down in Texas, they are slowly but surely making that transition. Now, Clint Flanagan, who I think is just a fabulous, representative of the direct primary care movement and the best poster person you could ever imagine for putting
Right.
out there, because he articulates it very, very well. It's a choice, it's a decision, it's a partnership between the physician and the employer, which eventually is the physician and the patient. And, during COVID, there was a lot more flexibility. Therefore, that model thrived during COVID because they were already set up to take phone calls. Yes. Did explode during that? Yes. And did they have to pay attention to some of the regs around it, particularly of advising people out of state, out of country? But it wasn't a bad solution during a very needy time for a lot of people. And we watched primary care practices pivot, traditional primary care practices pivot in that. And I think that there's some wisdom in how that model is set up, and watching and learning and exchanging. I'd say the one thing that I'm not bullish on, and everybody that knows me and is willing to listen to me knows this about me, is that credentialing is a business risk mitigation, and the providers do need to be credentialed to some degree. Now, I could go back and forth on this. I've had somebody say, well, if the employer asks if we're credentialing, then I guess we'll give them our answer, no, and see if they want to. And my position has always been, how would an employer even know to ask that question? Because they don't have that check sheet of what the BUCAs do as carriers to ensure that the physicians that are going to be in that network are who they say they are.
Right.
They don't have a DEA background. They don't have an onerous list of malpractice issues and so on and so forth. And I do think that there needs to be some checks and balances on that. And I'm not shy about telling anybody in the DPC space about it. But they're going to go ahead and do that as long as they possibly can, until the employers say, thou must, at least do the minimal reviews.
Mary, you said something in our prep call, because I've interfaced with a number of DPCs, and you said it, that if you see one DPC, you've seen one DPC, but you just named two that are moving aggressively into risk. They're not just taking their subscription fee and being happy. They're actually moving populations into risk, Nextera and Frontier Direct. But come back to I'm still fixed on the payment model. What you think are the best payment models? And I'll tell you, I've been thinking about this for a very, very long time. And some of my orthopedic colleagues may not like this, but I read an article by Michael Chernow called Hierarchical Payment Model. I don't know if you ever read that, but go in JAMA. Whether they like it or not, it just made sense. It is to empower primary care, capitate primary care, and let them subcap in episodic bundles to specialists. I know it's easier said than done, but boy, strategically and hypothetically, that to me was the answer. Because for primary care docs, if they're at risk for their capitation, then they're going to find the best subspecialists. Right. And because I'm a joint replacement guy, so easily to bundle, warranty. What do you think about that versus the pure subscription model? Because they're a little bit different.
They're very different. So first, I'm going to answer about the pure subscription model.
Yeah.
It's whatever the doctor says it's going to be for that community. And so you see ranges from, like mine just went from $85 per member per month to $99. There's some that are at $150, $175, because it really depends on the mix of services that practice or that entity wants to include and how they price those. Yeah. And then there's always the subset that is not covered. And my example is just, osteopathic manipulations is not something that every primary care physician does. So that makes sense outside of it. And it's not, the difference is that when you're dealing with an employer group or you're dealing with a fully insured payer, having better definition of what's in the cap versus what's not in the cap is critical. And you have to, Lisa will remember these terms, DOFers. You have to have division of financial responsibilities that are really, really clear. So there's no question about what gets paid on a fee-for-service basis and what's negotiated for that versus what is included in the capitation. And then the question is what are the reporting requirements? And how we did it back in the day, early on, was we just had zero payment. We had zero billing. So you could submit everything you did. And if it was these CPT codes, it just sat and didn't get paid. If it was outside and it was in the DOFR and it was designated, like a good example are vaccines. Why you can't hold a physician accountable for the cost of vaccines when they don't have anything to do with setting the price. You just have to be able, and you have to believe that there is a value proposition around having access to vaccines, and the plan is going to pay for it. And whether it's the plan's going to pay for them or the employer's going to pay for them direct, that you just have to have that. And it's really not that tough to do. And Steve, I totally agree with Michael Chernow's hierarchical. Yeah, I mean, we have to start prepaying our primary care physicians, and value-based care is killing them because there's this 18 to 24 month of reconciliation after the fact.
Exactly.
And, I mean, we're watching the disaster right now. We're watching the retailization of primary care fall apart and, day by day. Just look at Fierce Health, look at Healthcare Dive, look at conversations that each of us are having around here. It doesn't work. And what we're picking up pieces on right now is those companies that just wanted that race to risk, and they didn't want to do the stair step and use some discipline in, let's start with we're in fee for service. Let's go to pay for, P for Q. Then we go to one-sided risk, and then we can maybe go to full risk, but you cannot take any entity and just jump into full risk.
No.
It makes absolutely no sense.
No, there's an absolute curve for this part of the conversation. It's known, right? The progression of risk is really important. Starting at full risk when you don't have the foundations down at the front end with just basics on incentives is a recipe for disaster. And if you can't really manage the risk, forget it, which is part of the problem that we're seeing in the industry right now. The other thing is that the value-based models, and Mary, you and I have had this conversation previously, the value-based models of today, the way they're built by the BUCAs, have a limited lifetime span, right? Once you get really good at managing the population, there's almost no more opportunity for the primary care to do better because it's all retained by the plan. And the plan doesn't want to change their pharmacy approach. They don't want to change because they arbitrage everywhere in the model. And so the next step when you're at that point is to consider exactly what we're talking about, which is capitation or some form of, a percent of premium that is directed more by primary care. And that way they can manage the costs, manage the quality, and manage the outcomes to their satisfaction. And then there's the last component, and I'm curious how you square this in your head around just the overall survivability of private practice, primary care especially, but across the board with the way fee-for-service works and the way value-based payments work today. There just isn't an understanding that there are so many practices that are operating on the edge of personal bankruptcy because of the way the system's financed and because all the money in the system is going to all of these other component parts that are not responsible for direct care.
So well said, Lisa. So well said. I just took on a client in my little nest of the woods in Boulder County. It's a very privileged county, I might say. And it's a colleague of mine that I worked for him in an IPA 30 years ago. And he still is a robust practicing independent, internal medicine physician who has, and I'm going to use air quotes here, a concierge service, but he keeps it below the radar because he bills all of the payers still, and he bills Medicare. And what his concierge offering are services that are not covered by these carriers and Medicare. He offers some of the services to other physicians, the calcium cardiac scores and the lung CT scans, early detection scans. And so we're working on, he called me up and he said, I just need a thought partner. I need to think about how does this work? Because dirty little secret, I'm doing well. If these patients pay this extra money, and it's not $5,000, it's not $8,000, it's under $3. I'll just say that.
Right.
So it's affordable enough for a lot of people in this community, but now he's got a wait list of, just under 200 patients that want to get into the practice. I'd say they're more complex than the average patients that would be in a DPC practice. And how do we extend that? How do we grow that? Well, there are so few independent primary care physicians left in my community that picking and choosing and figuring out how you can get there soon enough, transition them into a like model, and have that tough conversation that yes, it's okay to charge this in addition to what they may be paying out of pocket, because you're going to have a different level of service and a different level of improvement, a much greater chance of improving the actual outcome and care. And what I heard earlier this week from the payers is that the payers just turn their head and ignore it because these providers have better outcomes than anyone. They haven't lost a patient to heart attacks. They've been able to detect 14 cases of stage 1 lung cancer and been able to cure lung cancer. And where do you hear that these days? Usually you get it at, stage 3, stage 4, and it's just hanging on and hoping and praying that technology catches up. So I think we have to do something radical. I think we have to do something different. We have to support that and look at these models to make it attractive to be a primary care physician. Make it sexy to be a primary care physician.
Let me ask, is it always I brought this up with other guests too. When you talk about primary care physician, in my mind, that's people who've trained in internal medicine and or people who've trained in family practice. Some of whom went to medical school, some went to osteopathic schools. The reality is, though, the folks who train primarily in internal medicine are much more dealing with acute illnesses and diagnosis and treatment, and not really have the headset of prevention of chronic disease, the way you just alluded, and early detection of other diseases. They tend to be more diagnose, treat, not thinking of the long term. The payers that you've alluded to, also, they're about renewal contracts. They're look short term, right? The employers, on the other hand, really have a long-term view, right? I had employees, when I was president of the hospital, I had employees that worked for me for 50 years. So I actually had their long-term care, not only because I paid all the health bills, but also, cared about them as people. So I've always thought there's two fundamental problems in this whole thing. One is the temporal disconnect, right? The long timeline that really you want physicians and providers, nurse practitioners, whoever they are, to think about to prevent these diseases in the long term that are really ultimately lead to the high cost, eventually claims. And then is the disconnect in the payment model, which is Steve was alluding to. You provide a service today, you get paid some fraction months later. If you do a quality thing, could be a year and a half later. It's not like people pay for what they're getting like they do in every other part of their business. But my question is, who are those providers? It's not your space necessarily, but don't we have to train people, whether it's nurse practitioners, PAs, to really think about this long-term view about prevention of chronic disease, early screening, early detection, access, short-term, immediate access, whether it's by your phone or whatever. Isn't there really a redesign of the whole provider side?
So you ask a really good question, and I'm going to be an optimist and a little bit of a dreamer because I've met physicians who really just want to do what you outlined, but they don't have the time or the support or the financial capability to do it because of the payer contracts that they're burdened with. This person I'm working with is very unique in that this is his passion. And this is how he wants to practice. This is how he built the practice. It's a mix of family practice and internal medicine with APPs. And he wants to grow this practice, not because he wants to make a bunch of money, but because he wants to improve healthcare outcomes.
Right.
And he's figured out a way to identify those that are on the wrong road versus those that can stay on the road. And those that can stay on the road want to be in that practice because maybe he got them back to the road. And those that are, on the wrong road can rapidly, with some of their direct financial support, get them on that road. And, it's a pretty small engagement for me, but I'm thrilled and excited to learn how this is going to translate long term. And if you talk to direct primary care physicians, they really are the same ilk. And they want to take care of the patient. They want to spend 30 minutes when they need to spend 30 minutes, but they also are pretty good at letting you know when your 2 minutes is up, because this really is just calling for a social call as opposed to
renew a script and stuff for
yeah,
that.
a script.
Often
They,
it requires you to come into the office, which is like crazy.
exactly. And they're really, I think really we should go to them to train those that don't
Right.
think they know how to do it. But I think deep in the heart of anybody that's a primary care physician, this is what they want to do, or primary care clinician. This is what they want to do. But Lisa, I'd be interested to hear what you have to say. I'm seeing droves of APPs leaving to go do something easy, like injections, like
Yes.
hormone treatment therapy. I mean, things that they can just do
Cosmetics.
on their own and manage. Yeah, yeah. And I'm like, no, don't leave the workforce.
I think we're at such a unique point in healthcare where there are enough people that want it to be better. But we've got the dysfunction of the existing system that we're operating within. And I do think that there are a lot of pieces of the direct primary care model and value-based care and other aspects that could be married together to create something that produces better outcomes and a more sustainable path for primary care providers. One of the questions that I had for you was, this kind of subscription approach, right? That's great for people that can afford it, right? You got the affordability issue, right? But the vast majority of Americans can't afford what they're paying in their own contributions or deductibles, and they avoid care, and more out-of-pocket costs just isn't there for them at the same time that everything else is going up. And so how do you square that in a model? What do you see as a solution that kind of takes the best of direct primary care and concierge medicine and value-based care, yet addresses the affordability component?
Right. Good question. And I'm going to be a little obtuse with my answer. I think it depends on the state in which you are in. And I'll just again use Colorado as an example. It's illegal to treat a Medicaid patient if you're a direct primary care here. You cannot take any cash from a Medicaid patient here.
Huh.
Even though and I'm not going to go on record saying this, I suspect that there are Medicaid eligible individuals who have figured out a way to have a direct primary care relationship in this state, because that's as good as it can get. Even though they realize, and it's very clear in these membership agreements, that it doesn't include this, and this, but they work together, and there's heart from a lot of these practices, including the semi-concierge practice that I'm working with right now, having a portion of your practice available for those that need. And they create those not because they're mandated to, they create that because that's the right thing to do. Now, can they load their practice up with them entirely? No. The subscription fee too can be shared employers can share that subscription fee. And I could make a good case.
Right.
If
So
you're an
we're-
employer paying for DPC, having a cost sharing initially, because that's offsetting the out-of-pocket side of it, depending on how the benefit plan design is written for the employer. And so I could make a good argument, well, there should be some cost sharing by the employee and the dependent. But if over time, and this is one of the challenges with DPC and direct to employer, is that it's not an immediate year one return on investment. It's maybe a little return on investment in year two, and it's year three when you start to see the return on investment, that you're running interference, they're healthier, they're taking more accountability for their care. And having the employee participate to some degree, however that can be worked out, and each employer has its challenges around this, is not a bad thing. It's not a bad thing, because you know what? They go out and spend, how much do you think they spend on their cable bill or their phone bill?
$100 a month.
Yeah, well, what about
300,
DPC?
or more.
It's $100 a month. When I first met Clint Flanagan, I asked him, how did you come up with this $74, wherever it was at that point? He goes, oh, it's a cable bill with, Excel. It's an electric bill. So yes, there's some subsidies. Yes, there's some complexities with it. But then you get into a state that just disallows it altogether for Medicaid or, patients at need or consumers at need. Then I don't know how you get around that. You have to go through the politics of it all, which is a state by state determination. And that's what makes it complicated, I think, for these jumbo employers that have footprints in many, many states. It's a complex deterrent because they have to adapt to what that state requires.
Yeah. opening up a lot of thoughts in my mind. But one of my favorite quotes in healthcare is this: healing is an art, medicine is a science, and healthcare is a business. I think we heard that from Porter and Kaplan, John, years ago.
Yep.
And I talked to Clint about his price point. And I say, Clint, do you have any idea how much value you're creating with your model? And he said, I just like the simplicity, just collect our
Mhm.
subscription. But I don't know if you heard podcast with Stacy with Dr. Kennard on it. And Scott's incredible, but saving one patient from going from high risk, low cost to high risk is $35,000.
Yeah.
Even if it's $1,200 for the employer, they're way ahead of the game. How
Exactly.
to
Right,
yeah.
exactly.
You're really incented to keep that patient with hypertension well controlled and diabetes well controlled to prevent the strokes, you know?
Willing to pay the $1,200 PMPM, but why am I paying the other 20,000 for what am I
Right.
getting? And that's where I hope this is going to go. Why am I paying the bukas $20,000 to not keep my patients, my employees
Right.
healthy?
Just have some stop loss coverage for the major things that you need.
Yeah, yeah.
Yeah, it's, Mary, honestly, I think a good primary care provider in any of these arrangements actually can save money even in year one. And I use my daughter as a nurse practitioner, family practice nurse practitioner. I listened to her talk about her patients. She's definitely prevented a bunch of emergency department visits in the first
Mhm.
year when she sees patients. Actually, her patients say, "You're the first person to ever listen to me," which kind of shocks me. These are 70-year-old people. But she's got a bunch of people who've lost weight, who've stopped smoking, who are now controlling their blood pressure. So I totally agree. Don't get me wrong. The biggest savings are going to be way down the road when you prevent the heart attacks, the strokes, the heart failures, and all of that. But you can make a difference early on. And then if you start adding a little bit of just pharmacy benefit management, looking at what people are getting and where they're getting their infusions, as opposed, not the hospital, but ambulatory sites, and then where they're getting their surgery. And as there's now transparency in price, or a little more transparency in pricing, you start saying, wait a minute, I'm going to send it to Dr. Schutzer at Hospital A for a hip replacement because Dr. Jones at Hospital B, it's $10,000 more, and the outcome's no better. So she's not at that point yet to know that because there's not enough data. They haven't explored it far enough to look where's really the most value once you start referring to specialists. But to Steve's point earlier and yours, you could start figuring that out.
I think you can definitely start figuring it out. And I agree with you. And some employers will see that return on investment in year one. I think it really is dependent on what sector they're in, if they
right.
do or they don't, and what the culture is in that company as well. Is it a culture of independence and accountability, or is it a paternalistic culture that just takes care of it all? And really, some people are just not going to switch out of that. One other thing about direct primary care that I'm just going to mention that is a question mark for me is that most of them opt out of Medicare. In fact, all of them opt out of Medicare. And I wish we could find a way to it's not like they don't know what Medicare is. It's not like they don't know what the rules of engagement are if some of their patients are Medicare eligible. And they're very adept at working around those rules and making sure that nobody, their patient nor them, step in anything untoward. But I wish we could have more support from CMS. I'm not sure this is the administration to ask that of at this point, and essentially go back to the future, so to speak, about primary care capitation. But I will say that I did have a very interesting conversation with somebody at Alignment, which is one of the kind of jewels, right now in the MA space. And this was last year at the beginning of the year. I started calling around to people, asking them about value-based care. Where do you think value-based care is going to go? And they were very clear that they were going to, because they started in California, and California is that foundation model where you delegate everything, that the delegation is being pulled back. And they too want to come back to not delegating out full risk, full claims payment, medical management, so on and so forth, but bringing it back so there's more of a balance between the payer and the provider, and they each take on what their responsibilities are, and looking at primary care capitation. So I think that you're going to see more start walking that back In fact,
Interesting.
Kevin O'Leary shared with me a excerpt he had, I think it was Lisa Gillis, an analyst for JP Morgan, talking to Charles DeVita. And they actually said they feel like value-based care is a nasty, bad word to say, any, acronym to mention anymore, because it, like, nobody knows what it means.
Right.
It's really it's whatever you want it to be. And I think I shared with Steve and John and Laura when we were doing the prep call, Lisa, I just decided, well, it's time to try AI. So I downloaded my GPT and started asking it about value-based care and whether it was successful or not. And it was in perfect agreement philosophically about what we're talking about. It has a lot of issues, and it's different for whatever provider specialty you're
Right.
targeting. And for some specialty areas, it really makes a lot of sense. I think episodic care and some value payment to orthopedic surgeons who do a great job and don't have the list of things that could happen once they let some of the replacement patients go after same day surgery. I think those are much more workable than placing a bunch of primary care physicians that are underfunded, under-resourced, and put them 100% at risk for upside downside on Medicare Advantage programs.
Right.
That's just
Yeah, I
crazy.
think one of the problems with value-based care is everything that we are talking about today kind of fits into that paradigm,
Yeah.
right? And to your point, there are so many permutations on how you can describe value-based care that it's kind of lost its meaning. And I do think it has the ability to deliver, but it is, to a point I made earlier, it is a tweaking over our systemic dysfunction, right? It's an attempt to control costs for a dysfunctional system of healthcare delivery today that only has a short life cycle, right? We need to face as a nation, we need systemic reform that gets to the points that you're talking about. How do we make it more sustainable for primary care to be able to enable them to do what they need to do to manage care, because they can do it, right? And how do we do it for specialty care? And how do we do it for hospitals? How do we do it for every component of the system in a way that makes sense so that everybody's focused on delivering an outcome and there's a return for that outcome, but it's not, fair game for other component parts of the system to manipulate the system to make more money, which is the way it's designed right now because it fits over to fee-for-service chassis.
And the fee-for-service chassis haven't been updated and improved to support the value-based care. And then I'll add this to what you're saying. I was reading something last night, getting ready for this, that most providers have somewhere between 12 to 20 payer contracts. Not one of those payer contracts is the same as the other in regards to how they're incentivizing or putting them in some sort of value-based care arrangement. And it's the payers that are making the decisions around what are the unnecessary tests, what are the unnecessary procedures. And we've seen, we all watched the Elevance rollback when they decided they weren't going to pay that extra for anesthesiology, and then there was something else. Who's making these decisions? And then if you forgot to read the news that day, and all of a sudden it's getting denied or pended, then you have to go through that whole scenario. And what I was sharing earlier is that I've talked to a lot of payer contracting people in the last few weeks, and the thankless is what keeps coming back. It is thankless to try to call a payer up and resolve an issue for a provider, whether it's a denial that was totally inappropriate, whether it was, could you clean up a roster so we could actually get them in network so we could, get paid for these services. It really is right now, the value-based care reward is coming into the payers far more than it's coming into the providers, I think.
The paradox, Mary, is we should all stop calling them the payers because they're not paying freaking anything, right? It's the employees are paying through payroll deduction. The employers are paying that exorbitant fee that Steve was alluding to. The taxpayers are paying for Medicaid. The taxpayers are paying for Medicare. Those people, those MUCA people, they're not really paying anything. So don't get me going. We are running out of time. I'm going to pass the baton to Steve for the final, hopefully optimistic future question.
Mary, this has been a very inspiring, really enlightening conversation, and we knew it would be. You've been in the industry a long time. Your journey has been very exciting. It's zigged and zagged. But I like it as we have a tradition here. Just put on your futurist hat for a moment, blue sky thinking. We focused on different types of primary care delivery, but if you had a think in the next 3 to 5 years, which is a short window, how do you think this can all shake out? What are your thoughts for the short-term future?
I think it's going to get worse before it gets better. I think the United States or each state on their own has to face a crisis in primary care availability because we are losing physicians, whether MD, DO, clinicians, because they've had it. And I think what will happen is it'll be a slow bleed of doctors just saying enough, leaving employment of whomever, whether it's a retail company or whether it's a hospital company, and there'll be some, depending on what age they are, will start over in a simpler model. I think those that are more mature might just throw their hands up and say, I'm done. I'm going to get a buyout. And I think we're going to have deserts of no access to primary care. And if you think healthcare costs are high now, wait until they're all going right to the emergency room and maybe an urgent care here and there, but right in and specialists seeing everybody without any of that support and information and kind of overview of a longer term relationship with that patient on a healthy and on a sick basis. And I hate to say that, but I don't think we're there yet. I think it's going to get worse before it gets better.
I agree with you.
Yeah, the darkest hours before the dawn. Then what?
In my perfect world, it would be adopting a primary care capitation program that was consistent regardless of the line of business of whoever is paying, whether it's the government or the plans or the employer. Because we have such a crazy mashed up mix that hits these primary care physicians and just hunting and pecking and trying to figure out who is paying this. The patient doesn't know, the consumer doesn't know. And if we could be consistent on the primary care side and make it more enticing and accessible for patients to have strong relationships with their primary care physicians, you're going to see a whole lot less volume moving over to specialists. Not that I don't have an issue with specialists either. It's just there's so much that the primary care physician can run interference on, treat themselves, pick up a phone and ask a dermatologist, what do you think about this? We have all this technology. They want to use it. They want to deploy it. Let's help them. And let's pay them to do that. And then when they get to a specialist, it's a great specialist that is going to take care of the issue, the unique single issue or two issues for that patient. But for chronic disease management, for like the metabolic syndrome, we really got to get that back in the primary care house, so to speak.
On that
note,
Mary, thank you so much. It was such a pleasure having you on today, and we really appreciate it. We certainly continue to watch the progress of this very challenging times we're in. So thank you. Thanks, Steve and Lisa. Thanks so much for being here today.
Yeah, thank you for having me. It was really great to have the conversation.
Thank you.
We want to take a minute now to introduce the new MTVA membership program. As a 501c3 nonprofit, we rely on support from our grassroots network to advance our mission of creating a value-based health system with high-quality patient outcomes at a reasonable cost. As we continue to grow and broaden our impact, we're excited to invite like-minded organizations and individuals to join our membership program. We're proud to offer two membership models, Ally Member and Trade Member. Tax-deductible membership contributions help us enrich the healthcare environment with quality content, including this podcast, and robust platforms to fuel discussion, collaboration, and advocacy that lead to groundbreaking solutions. For more information, including a full list of benefits offered, visit our website at www.movingtovalue.org/trade-member. The link is also in the episode description. Thanks again for listening and for being part of this important movement.